Well, hi everybody. My name is Tom Skelton. I'm the CEO of Surescripts. I've been here a grand total of 7 months, so this is heavily scripted, and I'm not allowed to deviate much. Otherwise, Kelly will get extremely nervous over there. So I'm gonna try and muddle my way through this as best we can. The topic that you see up here is connecting healthcare, navigating the interoperability journey. And I would tell you, frankly, from a Surescripts perspective, this is a journey that certainly precedes the rush of activity and press and noise in the system that exists today. We are fortunate enough to have been on this journey now for about 14 years and have kind of been an overnight success. You know, starting in about 2008, we started to move the needle pretty substantially and have had the opportunity now to really grow as the interoperability story grows across the system as a result of market opportunity, government influence, I would say, and certainly pressure from patients and from physicians. So we're very excited about the topic. We're very excited to have such an illustrious group up here with us, baking with me under the lights today. And what we'll do is start off very quickly with a brief intro from everybody, as well as a single question that we're going to allow them to take a crack at here. So Shahid, we're going to get started with you. You look ready for this one. So we're going to start off with the question, first of all, how do you define interoperability? And in that, if you could kind of weave your bio in there so the folks know who you are and what you do for us.
Sure, happy to. Thanks for inviting me here. Surescripts, I love what you guys are doing, and anytime you call, I'm happy to join, especially with this crew who wouldn't just be sitting. I'd just be happy to sit up here and listen, but I'll share some thoughts. My name is Shahid. I run a blog called Healthcare IT Guy, and I focus on what I call the BS problems. So stuff that people say are big problems, but they aren't really. They're just things that we need to do and work on. And when we started talking about this interoperability question, what I wanted to basically get the message out is we have no healthcare interoperability crisis. It's not a crisis. It's not something for us to be alarmed about. It's not something for us to be screaming about, like as if something major has gone wrong and buildings are falling down, et cetera. The crisis that we have is that our partners and the data that we want to share with them is not aligned well. So we don't know why partner A needs the data. We don't know what kind of data that they need, et cetera. So there's a lot of legal, political, and other problems that we need to solve. And if we spend our time talking about how we need more and more technology around interoperability as if that's the crisis, then I think we're looking at the wrong problem. So I did at Matthew's conference a couple of weeks ago, I did a talk on the no BS guide to interoperability. And the no BS guide really is understand that if you have the right relationships with the people that you want to share data with, you're going to be able to solve interoperability. And that's the simple answer to a very complex question.
Gee, thank you very much. Cris, why don't you go ahead and take a crack at that same thing? Any differences in the way you view interoperability? And please introduce yourself.
Sure. Well, I'm Cris Ross. I'm CIO for the Mayo Clinic, and I'm a Surescripts Alumni Club member. I can agree with Shahid that we don't have an interoperability crisis in the sense that there isn't a tornado bearing down on us. But we do have a problem as if we're living in a perpetual rainy day, and we really want to have a picnic. When I talk to my doctors about what they want, they're frustrated with the fact that they can't get labs on time, they can't get images on time, they get incomplete records. We have patients who show up today literally with banker boxes full of paper, and you know, the job gets done by hook or by crook. So yeah, we're sort of gutting it out. But when you look at the fact that you know, Rand and Dartmouth said a couple of years ago that about 30% of healthcare expenditures are wasted because they're not reflective of best practices and because of duplication and so on, we have to say that there's a really serious problem. So I'm happy to call it a perpetual rainy day, but it ain't pretty if you're wanting to picnic.
Yeah.
Thanks, Cris. Venk?
Yeah, Venk Reddy. I lead Connected Health for Walgreens. So when I was thinking about this question, I thought, you know, being a techie, I thought I'd answer this with a mathematical equation. So what is interoperability? To me, it is exchanging data, matching patients, plus interpreting the data, plus use. Without all of these things, interoperability is meaningless. And I completely agree with the comments from either of the speakers that interoperability is possible. You know, as long as the two organizations make it a priority, smart analysts can make it happen. I mean, there's enough technology, enough capabilities, enough terminology to support it. So there's no excuses anymore. It needs to get done.
Thanks, sir. Matthew.
So I'm Matthew Holt. I'm write the healthcare blog, and as Shahid mentioned, I also run the Health 2.0, co-run the Health 2.0 organization within Dubai. And I have two perspectives. One is kind of a confused industry observer, because now we've not only got HIEs, Direct, Blue Button, now Fire and Argonaut, but we've also got Commonwealth and now I'm going to get lost here, eCareway, and what's the other one called? I'm lost, right, and I should know something about it. So you can imagine everybody else out there is completely confused about who's doing what around interoperability. We know, and then the other thing I am now is a patient advocate. And if you saw the healthcare blog this morning, I finally, after 6 months after giving the talk at Health 2.0 last year, wrote up the story of my kid, Aero, who had 4 different doctor visits with 4 different doctors in his first 8 days of life. And in no case did the paperwork, even though 3 of them were had the word Sutter on the door of the organization and had the word Epic on the computer, although one of the computers was backed up against the wall with the screen facing against the wall, so not sure how useful that was, but anyway. In no point did the data get between these and flow, and in fact at one point it was given to me on a piece of paper, and it was he had high bilirubin level, which is a potentially dangerous syndrome for a young kid, and at no point did it get transmitted by computer to computer as to what that number was. What's worse, and just to add another little sort of wrinkle to the interoperability problem, the data came from a thing called a spectrometer, which you put against his forehead like this. You measure the number. That, of course, got typed in once by the doctor into our Epic system, and once by me into a tool called Billy Tool, which tells you, if you put in the weight and the age of the kid, whether it's serious or not. So you've got some potential for data entry errors there as well, especially when the pediatrician in the room with the wall, the computer against the wall, got a piece of paper out. It said to me, what was the number? And I said one number, and my wife said a different number, because we couldn't remember. So we have interoperability, and it's mostly, unfortunately, people's heads. Not good.
Mm-hmm. So let's pick up a thread that you just threw out there. There's a lot going on in the industry. There's a lot of fragmentation in the industry. You've got hundreds of EHRs. You've got thousands of hospitals and health systems. You know, we're trying to connect 800,000 providers. You've got 300 million patients. You know, a lot of standards bodies, a lot of alliances, et cetera. Cris, is this normal? Is this natural? Will this sort itself out? How do you view all of that?
Well, part of the challenge is 5 years ago, about 20% of doctors were using an EHR, now about 80% is. So go us, we did well on that. At the same time, if you
Thank you, Chinese taxpayer.
Exactly. I don't know what that means, but I'll follow that later.
Who paid for it?
Yeah, well, there you go. On the other hand, you know, most of the systems that people are using, they're not highly thrilled with, and they're first generation to a large degree. We also have no economic incentive today from a payer perspective to get people to share data with each other. So when data is exchanged today, it's because a patient needs and wants it, and because it's in the interest of the patient. Healthcare systems sort of make sure that it happens to some degree. So I don't think it's a particular surprise that we have a little bit of the discontinuity and challenges that we have today. I'd also say, even if we had perfect technology, if we don't have business models that support interoperability, we still probably won't get there. So I'd say technology is necessary but not sufficient to be able to solve the problem. You know, when the meaningful use standards came out, and the requirement was to have a document that you could produce and give to someone on discharge or at continuity of care, that was great. Smart people started looking at each other and said, now how exactly are we going to move these messages from one place to another? And essentially everything on the ground was inadequate. So we as a nation sort of made up this thing called Direct in a hurry. It's not bad. It has some good things. It has some bad things. But it's clearly first generation. So I think it's getting all untangled to a certain degree, but I think we're going to have to go through at least another 1 or 2 iterations of messiness before we come out on the other side. But of the whole alphabet stew that Matthew listed, I think actually FHIR and FHIR-like standards are probably the most interesting. Because the reason, and I'll shut up, is because they look like eBay and Google and Amazon, and it makes healthcare look more like the internet. And the more we look like the internet, the better. The more we look like proprietary technology, the worse. And we've been doing a lot of proprietary technology just because we think it's fun to do it that way.
Right, right.
And Shahid, we had Cris mention, there's got to be a commercial arm to this. How do we sync the business models up? How do you get the partners aligned? And I would say just as importantly as getting them aligned, how do you make it work out so that you've got demand for the data that we have that matches our ability to provide it? Because I would submit that there's a lot of data that people are dying to push through the system and are willing to pay for, but the consumers of that data are saying, really, no thanks. I've got about enough of that. I don't really need anymore.
Yeah, I think that's a great point. So when you look at the demand generation part of this, which is probably the most important piece, it is absolutely true that we had to give out $30 billion for people to use technology that they would have at some point ended up using anyway. So when you look at the Meaningful Use program, the demand generation was required through an incentive program. And like Cris mentioned, we don't have that incentive program for the interoperability requirements that we have. So I think what will work, and these are, in other industries, what we use are what are referred to as value-added networks. So when you have a chain of partners working together, and in any other industry, a suppliers, for example, a device supplier working with their connected partners or customers, et cetera, would all be working in a value-added network, and they would all come together and say, this is the data that we need. In no other industries do we start to say we need seamless interoperability between every bank and every piece of record or every retail shop. I mean, Walmart has to talk to a little mom and pop shop somewhere in Iowa. It doesn't happen in any industry. The reason we can't get anything done is because we are defining the problem in a very bad way. Seamless interoperability is never possible because business models are all different. What is absolutely possible is interoperability today using FHIR, which I love, even without FHIR, using basic HL7 and everything in MU stage 1 and 2, can get to basic interoperability within a value-added network. So when you put people together, whether Surescripts is in the middle or other people are in the middle, there are those pipes that are available. And one example that you can just look at is 10 years ago, when in 2004, 2005-ish time frame, none of us would believe that within a few years, upwards at 60, 70, 80% of all prescriptions would be electronic. Yeah. Yet today, it's just a normal thing that we say. It didn't happen by magic. It happened because people at the PBMs, pharmacies, et cetera, got together and said, we have got to fix this. And that's what's happening. So that was a value-added network. There was a private network of very important bodies that got together and said, we're going to do this. And I think it's going to take those bodies. So when you have a great CIO like Cris saying in Mayo and their community, hey guys, we're going to get together, we're going to create a value-added network. This is how we're going to exchange data. This is how you're going to exchange data. It's going to take months and a couple of years, perhaps, to get all the legal wrangling and everything done, but it is possible. The moment we step back and say, I'm not looking for seamless interoperability across every healthcare institution in America, which is a daunting task. I mean, we've never pulled that off in any industry, let alone one as complex as healthcare. And I think when you look at the business model question, the business models don't have to be invented, they have to be reapplied. Applied from industry A to industry B to industry C. And when you look at it, we're probably very close to the retail side, where not every organization is directly interacting with each other as participants, but they need to connect with each other in order to share enough data. So advertising works this way, retail works this way, et cetera. So I'd say business models are possible, but let's not just look at ourselves. Let's look at other industries that have solved this, and I think we can get pretty far.
So Venk, tell us a little bit, look around the industry. Tell us, where's interoperability happening? Where are we having some success, and where does that start to take us?
Absolutely. I just wanted to add one more comment in terms of, there's so many options. So I completely agree with Shahid. You have to look at the use cases. Sometimes you don't need bidirectional, seamless interoperability. It could be using direct, you're doing asynchronous communication based on certain use cases. For instance, at Walgreens, we support Connect, Direct. Now we're going to soon start to support FHIR. But we have certain use cases where these things make sense, like immunizations, for instance. In order to communicate that back to the primary care setting, Connect is adequately sufficient for that kind of intervention. But I mean, I meant to say direct. Did I say connect?
You did.
But anyway, I meant to say direct. But connect, we need connect for query-based document exchange. So those use cases are different. But where I see interoperability working very well, again, I have to tell you a little bit about something that I was quite fascinated. Back in early 70s, since the 70s, the auto industry, you can take any car, any automobile, any make, any model to any dealership, and they're able to read your diagnostics. And this is from 1970s. So that's basic interoperability, if you ask me. At least the codification, they're able to read this engine diagnostics. So if you look at that, that's amazing. I mean, imagine the cars start to transmit this kind of information to you. You have your apps that are receiving this information. That's going to be, I think that's where the auto industry is going next with it. But in terms of banking, I think you talked about it. You got to do interoperability where it makes sense. You don't do interoperability for the sake of doing interoperability, like the banks. That's a good example. They don't, and the retail setting is another example. They don't all talk to each other just because they need to talk to each other. Is there value? And I think the healthcare system also needs to look at that. Where is the business case? Does it make sense? Is it really helping the patient at the end of the day? And do we need this type of expensive interoperability, or can we do with lightweight interoperability that can be sufficient?
So Matthew, we've got a lot of opportunities there. Where are the barriers? What are the things that are getting in the way of having us move more quickly down this magical path to interoperability?
I think the word Shahid said was value-added network, which involves alignment. So if I go back to, and it's a long time since I looked at it, but the Surescripts and the prescribing stories, it made sense for the Surescripts owners because the pharmacists were spending all the time and effort typing in, and couldn't read the scripts, and there was a mess there, and the docs were semi-forced into it, right? But so you got value alignment there. We've got really big problems, right? Go read the New York Times, Elizabeth Rosenthal's articles, or Steve Brill's stuff. There are a lot of players in the healthcare system who are quite happy to sort of be out there on the edge, don't want to be in any kind of network because they want their bills to be paid in full, and it's really quite remarkable what's going on in terms of literally price gouging in many parts of the country by different players across the healthcare system. The assistant surgeon who put in the $117,000 bill, which Aetna paid, right, for one procedure, that's not a complete mystery. If you think about where are we going, eventually we're going to go to a world of accountable care organizations, who are aligned and want to figure out how to get all this stuff and care about whether the patient had a test elsewhere. But we're not really there yet. So I'm concerned about the basic funnel economic value equation. The other place I'm really concerned about, it matters to me personally, is in the safety net. My kid, the one who left the hospital, the fourth place he went to, which is regular pediatrician, had been on Epic with the rest of the system, with the rest of the other systems that he went to, but had actually changed because it was part of Sutter, a big system. It was a clinic in a poor part of town, and it moved to a federally qualified health center. They ripped out Epic, so I had his sisters and would have had his records on that to see in my chart, and they put in NextGen, and the clinic there is too, it just doesn't have the resources, the ability to put in even a basic patient portal. I don't even know if I ask them to do a direct, I'm going to ask them next to do a direct message because I reckon I can get that out. But I mean, that's a struggle for them. And for me or the other patients there to go and say, I want those records. If I took my daughter to Walgreens and I gave her a flu shot, if somebody at Walgreens wanted to see the other immunizations she'd had, how they've got that? I mean, I don't know how they would have started that equation. So there are some problems. And the one thing that we also got to remember is that who gives a rat's ass if Walmart doesn't know that I went to a corner store and I bought something? But in the end, I might actually, you might want to know that I went somewhere else and had some other procedure or had some other drug or had some immunization, because that's part of the totality you want in front of the clinician who's treating you. So, yeah, we have a bigger, more complex industry that's cared less about this and has a bigger need. So, are we going to start grading yet? we started grading. Last year we were grading. So.
Yes.
No, that's out there.
We'll get there.
Yep, we will. We will get there. So, one of the questions that we kick around is, are we chasing the right things? You mentioned use cases. what are the things that are rising to the top that you look at and say, these are prime, these are the types of things that the industry should tackle aggressively because they're doable, there's understanding of what the real problem is, and there's agreement that it creates value, and the value then can be distributed appropriately among some business models. Shahid, where would you start?
I would say that when we look at the different facets and the way healthcare works, you think about things like diagnosis-based interoperability. So are we getting the diagnoses everywhere? I'm just going to hold this in a second. Are we getting all the diagnoses in everywhere we need to go? Like in the case of medications, one of the core things that was focused on first was allergies. Just make sure the med allergies are there. That doesn't mean other stuff is not important. Just got to start somewhere. So when you say allergies, et cetera, with medication, the same way we did that, we need to look at diagnoses, procedures, and therapies. So we don't need everybody's data everywhere. What we need, and again, this is not to say I would not love to have that. But if we keep dreaming about things and never start somewhere, we're never going to end up anywhere. So when we look at the problems and you say, well, where is the most complexity? In therapy, it's in diagnoses, it's in medications, et cetera. When we start with the basics and say, what is the first thing that we want to interoperate? Let's just make sure we know everybody's allergies and their medications. The second thing we want to know is, what disease conditions have they been diagnosed with? The third thing we want to know is, what are the therapies? What are the active therapies that they're on? And when you work them one channel at a time, one problem at a time, we will see that it's not going to be all in months. So this is all going to take years, but it will come. And that's why I like the example when we see things like medications, et cetera. That's a major problem. We tackled it as medications. If we would imagine that in 2005, as this was all starting, we said, well, no, forget medications. We just need to solve all of interoperability. We wouldn't even have basic medication integration. So now we're saying, okay, we're not, by the way, I don't want to make it sound like the meds integration is licked. It's not at all licked. It's just much better than it was 10 years ago. We can't say that about any of the other major components that were, these other channels if you think about them. So when you think about healthcare as a totality, we lose. When you think about healthcare in specific problems, when you focus in particular areas, and there are those that can work on certain areas, put resources to it, make things happen, without holding back and saying, oh, we're just going to wait for some magical regulation to come, or we're just going to wait for some magical technology to come and save us. Ain't no technology coming. Ain't no regulation coming. This is it. The people are here. We have to solve it. And if we look at each other and say, are you responsible enough to do it? Are you responsible enough to do it? And someone says no, our biggest demand generation problem is we don't punish the participants in a network that don't add value to that network. Yet we want them to continue participating. This doesn't happen in other value-added networks. In other value-added networks, when you can't participate, the other members help bring you up or they toss you out. In healthcare, we've got to do the former, right? We've got to make sure that each of the participants move up. But the key thing is, it is possible. We have to step up and say it's one step at a time, in one network at a time, trying to connect everything up. That's how it that's how it's worked everywhere, and it's going to work like that in healthcare as well.
I'll just add one comment to that.
Sure.
So, right on. I mean, the 4 sections that you talked about, there's industry terminology that's available. All the EMRs can consume that terminology. If it's codified, not every part of the note needs to be codified. Those 4 sections, if we do a good job at that, I think we can give ourselves an A and move on. Right. It's possible. The industry has enough terminology standards that we could use to codify those sections. And I completely agree with you. Every section of the note doesn't have to be codified. You know, the things that we can do, we should do.
So Venk, you opened the door. So now let's talk grades, because I know Matthew's excited about this opportunity. I'm going to let you go first. Before you were a bit all over last year, as I recall. You gave us multiple grades.
No, that was Shahid.
That was me. I like to keep things complicated.
Well, before we go to grades, though, we've got to mention that we're talking with some. You guys are starting to sound optimistic, which is great. But didn't ONC on Thursday last week come out with a report saying that there are a bunch of actors who don't want this to happen, or information blocking, including actors in this room? Well,
right.
It's Bonn. So, we've got to really be careful about the concept of everyone wanting to be part of this value-added network, and there are good reasons not to be part of it still. So, let's be cognizant that this is not like pushing a ball downhill. some parts of the hill are still uphill.
Right.
The ball is on the bottom of some hills, right?
Yeah, and that's a great point. In case you missed the reference, last week ONC produced a report to Congress. Congress had sent a request wondering, hey, we spent all this money, why is everybody complaining about interoperability? And so the report basically, in summary, said that there are some folks in the healthcare value chain that are actively blocking the sharing of data. Now, while this was completely obvious, I mean, how many believe that that was news? Okay, nobody raised their hand just for the videos. That's true. It's everybody knew that active blockers are there, and we know many of them here. But that still doesn't solve our problem, unless they're named, which hopefully this is step one, and then somebody's going to get called to Congress, and somebody's going to be forced to say, name the person who's doing this. And that's when we get to reality, because it's all conjecture at this point that vendor A wants interoperability and vendor B doesn't, or institution A wants to do this. These are all conjectures, and until we get to reality, we can't actually solve the problem. So I'm actually more optimistic because of that report.
Yeah.
Enormously. I mean, I woke up when I saw that, I was like, holy cow, this is great. This is going to be the thing that at least begins the discussion. And once the discussion starts, that's when we start figuring out who's got the value, who's adding the value, who's not adding the value, and now we can move forward.
So you asked me about grades, so let's start with the grades. I think last year I was like a C minus.
And what are we grading exactly?
C plus.
What's the course? Say it again that we're grading, just for the record.
No. For the record, the system has had an infusion of capital to move it down the path, right? The first monies were laid out there to get everybody online and get EHRs out there, 80%, etc. Now we're on the longer journey, chasing this elusive pot of gold under the banner of interoperability. How are we doing? Set aside the noise, set aside the hype, set aside everything else that we hear in the market. How do you gentlemen feel that we're doing?
So I'd say that if I was a C plus last year, I am up. We're at a B minus. I've personally now sat behind, actually she just left. My orthopedic surgeon came to see me. Ina Sire from UCSF was here. But I've sat behind her and sat behind some of my daughter's pediatricians, looking at Care Anywhere or Care Root. Which one is it? It's the Epic one that does other Epic systems, and you can see other Care Root. You can see other records come from other places. You're starting to see. So there is within that one system that's pretty ubiquitous in many big centers, many big population centers. You're starting to see some, the ability to see different parts of data. I can personally go now to my 3 or 4 different providers and see some data about me on a portal. This is good. And then I can go to Walgreens, and I've actually successfully got my Fitbit into the system for my rewards, but then I lost it. Now I have a new thing, which I'm sure you guys haven't built in yet. But you've got companies like Validic and others who are like plugging other stuff in to these systems. They just did a deal with Meditech and Cerner, I believe. But, and then you've got the whole notion of these APIs opening up. And actually, Kim Kruger and myself are doing a bit of work for the California Healthcare Foundation, looking at how easy or hard it is to build a little piece of technology or build your app on top of one of these big EMRs, but it's clearly getting easier. However, it's all great for my kids' pediatrician specialists to be able to see the other Epic records, but when they go back to their day-to-day immunizations at the community clinic, there's no connection there, right? And you've got to say, I get the value chain, but the value chain is still in my head, right? I need to get it out of my head onto some connectivity, some device that makes, and I suspect, I hate to say it, and Adrian Groff will probably agree with me in the front row, the only person who actually cares enough about this is going to be the consumer or the consumer's agent, because it's going to be too hard for all the little people who touch, all the provider organizations of all different types who touch you only once or twice to actually figure it out. So I still think it's going to have to be consumer-driven or by consumers' agents, and the biggest agents of consumers should be, and have been asleep at the switch enough they're only here, are the people paying for the care, who tend to be health plans and employers. So, and CMS, but that's a different kettle of fish. So I B minus, and we can get to B plus without too much trouble, I think, but we need a shelf to get there.
Cris, what's your view?
I think we get a C, and we're in the 3rd grade. But I think we need to be in the 11th grade. I think we're in terrible shape, frankly, with respect to interoperability. My clinicians cannot get the data that they want. There's some shining areas like meds, we get an A. I think labs are probably about a B minus. Radiology, see. But in terms of our ability to get data in from other healthcare settings and to get it back out and to make it easy for the clinician and the patient, I think we're at best incomplete.
Okay. Venk?
I'd give B for effort. I think
you got grades at your school for trying hard. I like it. Tried hard. Good wrong.
Because I think there are enough for the protocols. I think Direct. Again, I'm on the board of Direct, and I think Direct Trust has done an amazing job in terms of adoption, in terms of number of messages. So Direct's done an amazing job. Connect as well, and then now with Fire, I think there's enough ways to do interoperability. Again, I wouldn't. The grade is not for seamless, bidirectional, amazing interoperability, right? It's good enough for that type of interoperability.
Shahid?
Right. So I'll leave you with, again, a complex answer like I did last year. So when you look at the people, process, and technology around interoperability, which is how we do enterprise architecture, right? Are the people ready? Is the technology ready? And is the process ready? What I'd like to see now, and within 1 year, an enormous change has happened, and we've got things like APIs around Fire. We've got all of the MU and MU1 and MU2 nicely gestated. So I think from a technology perspective, we're probably in an A- that we have the infrastructure from a selection process, the specifications, protocols, et cetera, that we need if we're serious about it. Now comes the question of people. Are the people ready? I think from a engineering perspective, there's still growth. I give most of our engineers a D+ or a C- to say, are they ready? Do they understand the protocols? Do they know when to use HL7 versus Fire, for example? Which APIs do you use? They're not ready. So we have engineering people that we need to improve. And then the physicians, the consumers, the people who need to use this data, we've got to figure out how they can demand not interoperability, but I think what Cris said is right on is, I want to know this about my meds. I want to know this about my labs. The more we give engineers, so I'm talking purely as an engineer, if I get a generic request, I don't know what to do. Doesn't matter how smart I am, I just don't have the answers. But if I get a specific request to say, I need this data, that's a pathway to what I would refer to as profitability or success. So you can move there. So when you look at technology, I say pretty good grade. People, pretty bad grade, because we can't describe the problem and we don't really understand how to do it. Process, and I think where Tom was talking about the business model, we have to have an F. We just don't understand it. We don't know what to do. We're all here talking about patient engagement and care coordination as if these are magical things, when we haven't even described what the heck does it mean. What does it mean to engage with a patient? What does it mean to do care coordination? And this is not I'm not trying to make this an esoteric taxonomy or a discussion problem. What I want to say is, this process problem, the business model, means different things to different people, and not the majority of the players here are not evil. They just don't, we haven't sat down and said, this is what we need to do and this is how we're going to do it. So if we can get around the argument, and this is probably my central thesis, is let's stop worrying about the tech. The tech will take care of itself. Worry about educating the people who are building this stuff so that they know what is available. Worry about educating the demand side about how do you demand the right thing. And then let's figure out the business models from a value-added network perspective or other areas that we know we can succeed with because it's succeeded in other industries. So that's really what I would say from a grading perspective, from a tech, process, and people side.
Well, gentlemen, thank you. We're going to bring my questions here to a close and see if anybody out there has any questions they would like to throw at anyone. Any questions from anybody?
Can I make a connected but somewhat
You're
different
going to make a leap
comment
here, aren't you? You're going to take a leap.
A little bit. Well, not.
It's a hard right turn. I can feel it.
Well, so here's. So far as that, so we were in the. Why weren't you there? We were Cris and I, and I don't know why you two guys weren't there, but we were in the Argonaut group, right, which is downstairs, meeting down in the basement, which is where the important stuff happens to HIMSS, right? In the basement, Anish Chopra running running a sort of loosely affiliated group around the Argonaut project, which is helping, speed up Fire, basically. And then at the end, the latest CMS guidelines, or not guidelines, but the meaningful use piece came out, which also came out last week, which is the idea that instead of having it to be 25% of your patients who had to interact with their record online, one patient was good enough. And there was some argument back and forth about how this, whether it's a good or a bad thing. Everyone in the room, apart from Cris, thought it was a bad thing, actually. I was kind of teasing about that, but Farzad then said, here's what we've got to do. We've got to motivate people because the consumer is the person, the patient's the person who's going to get their data. So he's advocating for July the 4th to be Data Independence Day, when we need to get 1 million people to request their data from their provider. Because we've got to generate the demand side. And I don't, maybe a stunt like that is how we do it. It's very tough for me. I am the only patient representative at my daughter's clinic who goes in and dares ask for the record, and they kind of smile at me sweetly and say, we hope to get there one day. And I don't know how we get them to the point where it really matters.
That's a great point.
Hi. So does it matter what the EHR system is for getting interoperability? We have a number of systems. I mean, Epic is the sort of giant footprint, but do we need, does that matter? I mean, do we need to all be Epic or something to make this work?
Heaven forbid. No, it shouldn't matter at all. They should interoperate.
Right. Yeah.
Well, I mean, the point is not does it not matter, but we're not going to go to a world in which every single person in
Right.
America and every single doctor has Epic. We're just not going to go there.
Right.
In fact, Judy wouldn't even allow it, right?
Right. And actually think about the angle in a slightly nuanced way, and that is, do we need a single vendor? The answer is absolutely no. No question there. What the big question, though, is which are the EHRs that have the highest utilization? Because interoperability is not about basic connectivity. It's actually moving real data. So if you have one EHR in an organization, which might be the best from a class rating or something else, but it doesn't have high utilization, that system is just as bad as not having any interoperability at all. Even with full interoperability and low utilization, you have no interoperability. But if you had another system, say it was a very basic EHR, didn't have all the bells and whistles, but it was simple enough that meds were getting in there, diagnoses were getting in there, et cetera. Forgetting meaningful use for a second, I just mean any utilization of meaningful value at all. If you have utilization and you have the tech and people, things are good. If you don't have utilization, this is the big problem, is there actually, we've had EHRs in many places before, there was no utilization. Now utilization went up because of the MU incentives. MU is being pulled back. I mean, just like this example, it's going to be continued to pull back because we, as an industry, it was silly for us to put in the requirements at hospitals or health systems, et cetera, the way meaningful use said it should be done. It's not, that doesn't make any sense whatsoever. Like one example I give is, back in the late 90s, when the HIPAA regulations first came out, HIPAA was broken up into two pieces. One was the thing that we all think about, which I hate, which is the security part of this, security, privacy, et cetera, very important piece. But the other important piece was the fact that CMS started to require electronic transfer of data. Now, roll back to that time, and at that time when they said that, people were like, there's no way this is going to happen. It's going to take forever. In less than 3 years, the vast majority of systems supported that electronic data transfer because you couldn't get paid without it. That's a heck of an incentive, right? So when you look back a few years and say, how do we pull this off again? Let's not tell Cris at Mayo, you have to do X records and Y this and Z that. Let's tell him, if he was told, for example, that in order to get Medicare payments, that Medicare now requires this summary data with this much information, et cetera, to compute a score, and that score then got you paid, which is what's going to happen with value-based systems, et cetera, the payment reform itself is going to do far more than any incentives program would or anything else. But just remember, just because we have systems doesn't mean that they get used. But when you have incentives aligned with usage of data, so what was the central thing that we learned from HIPAA? Is if you use the data that you force people to create, you will get interoperability. Because nobody wonders, could we send an 835 transact? No, you just do it because you're gonna need to get paid for it, and that's where it came in. So, like for example, if CMS came out with even restricted rules or less rules, but they're just as silly telling a hospital what data they should collect, what does it matter? The question is, what data should you use? How is it going to be used? What is the value that you're going to get out of it? Those are the discussions we're not having. as you can see, I could go on for a while.
I've never thought of that from you.
No.
Hey, Jared Ferguson, CTO of Royal J. How do you guys see the consumer role playing out in this interoperability story, specifically with things like Apple Health Kit, Google Fit? You had mentioned the reason why this might be more successful is because our APIs are starting to look more like theirs. Eventually, a solution could be, the patient on their wearable or a chip or something, owns all of their PHI data and could be a potential solution. How do you guys see that playing out over the next 5-10 years?
So I can take a shot at it. We've got a Mayo Clinic patient app that you can go get from the App Store and Google Play. The iOS version downloaded about 500,000 copies of that, and only some of that was for patients. The majority of it was for others. We have HealthKit integration with it. We do a lot with Google today. If you search various things, you'll see an info box with information provided by Mayo Clinic. We think that's really great from a social media perspective. We're really active in Twitter, a bunch of places like that where a lot of things are happening. So there's clearly patients who care about their health and are interested in getting health information. We divide it into a quadrant of 3 that we think people are interested in: health information, health guidance, and health care. We're pretty good today on health information as well as other places are. We have 320 million unique visitors a year that come to mayoclinic.edu to look for information. We have a lot of people who come to us for care. The frontier is getting the guidance part right. When people say, I've got some condition and I want to do something about it, I want to be proactive about it. I guess my personal thesis, not necessarily a Mayo view, is that people don't really care about their health information until they do, and by God, at that point, they really care about their health information. So a lot of our systems need to act in the same way that financial systems work at tax time. There's a lot of people who don't look at their portfolio all year, don't really pay any attention to it. Their 401k just steams along, whatever. But by God, when it's April 14th and they got to file their tax return, they want to be able to get their 1098s or whatever the hell it is for dividends and interest. I think that's what people, to a large degree, want about healthcare. And then after that point, they may have a very high level of engagement. So we have to have the tools to be able to support that 2 to 5 to 10% of the population, whatever it is, with intense information. For everybody else, it's going to be, hey, I'm diabetic type 2. What can I do to live, eat, more healthy? Those kinds of things are the kinds of information that people really want. They probably don't want their hardcore health information. They want health guidance, if that makes sense. So, whole spectrum of what people are interested in. And we'll see where we go. I just don't think the quantified self movement is going to become a mass movement, to be perfectly honest. If it is, for those people who are into it, great. They'll live healthy lives. But for the rest of us, other techniques will suffice.
I'm sure Venk will tell you why you're wrong, but I will as well. I mean,
From a
bring it.
standpoint,
go ahead. One thing I'd add is that there's 3 things, right? There's one is the data that's collected in HealthKit or on the phone or in the Fitbits or whatever. The stuff that's the Internet of Things stuff that's outside the clinic, that's going to stay outside the clinic, and there will be people like a Walgreens or whatever who will take those types of data and steadily introduce it into what we think of as the sick care system. Right? But I think that's a different aspect compared to the issue of me getting my data, immunization records, my meds, and that the stuff out of those 2 are different. The other thing that's I can't believe you didn't bring this up because you guys are involved is Better, which is a really cool app which does provide guidance, right? And to me, that's the first sort of camel's nose under the tent of a bunch of services being delivered by smart people in Silicon Valley using things like the Mayo brand and the Mayo advice nurses, right, to help introduce a better way to figure out how to deal with your health condition.
I think you're absolutely right. The thing that's interesting, though, is I think the things that we think about in health interoperability when we're at geekathons like this, very little of that data will filter out into the better sort of world.
But those advice nurses and those other people with those apps and those services, they will need this kind of data, right? They need the basic stuff that Shahid's been talking about.
Totally agree.
And I think that the great news is that you've got what are emerging as big clearinghouses. Surescripts is one kind of clearinghouse, but I'm thinking of Walgreens is like a big consumer clearinghouse, and WebMD you guys got activity with, and there are going to be others. There is this big company, and you may not care about your health data, but there's a company in Cupertino which is named after a fruit, which I think has got a new product, which they think is, and they have a competitor in Korea who's got a watch band with, So I'm not so sure that people aren't going to care, or at least record it in the background. It'll be there, and
We should
it'll
put
happen.
a bet on it. You know what? We should put a bet on it, Matthew.
Okay, so
I'm
here's my
willing to
bet. How many of you in the room know what your cholesterol number is? Oh, come on, you're lying to me. Only 2 of you know your cholesterol?
Touchdown.
Rubbish. You are lying, lying, lying.
They all like
You
Cris
know.
better than Matthew.
They didn't like Cris.
Right.
I
They
just
didn't
don't-
know.
I don't-
They didn't know.
I'm very surprised to hear about that, because I think most people, there are some numbers now that people kind of know and know something about, and that pressure's going to increase. And we'll see.
Yeah.
Let's ask one more and then we'll wrap it up here.
Stage 3 proposed rule has a fairly strong statement about APIs and the ability of patients to specify and delegate through the API. Let's assume that it survives into the final rule. How likely are we to be back here next year giving grades on interoperability in the range of B to F? Depending on one thing, no, I'm asking a specific question on whether we also need to shut off the alternatives to using the API in order to achieve interoperability. Maybe not in a year, because shutting off all the other dark networks like Commonwealth and state HIEs that don't interoperate and Epic Everywhere and everything else. So given any of you, how many years can we achieve interoperability without shutting off the dark networks? And how many years will it take to shut off the dark networks?
I can say a quick note about that. I think that as we've seen in technology, tech is created very, very quickly, but it takes forever and a day to ever go away. So, I don't see, I don't see that an EDI batch mode is necessarily a dark network by itself. Certainly, if there are blockers of data, like what the ONC guys were saying, those should be dealt with. But by itself, whether it's HL7 or X.12, et cetera, these aren't going anywhere because there is more HL7 and X.12 going on right now, even in regular internet.
Let's hear the answer.
Well, so that's a big challenge. Meaningful use 3 is much bigger than it should have been, unfortunately, so you have to take it in that context. I don't believe that if there are so-called dark networks that they're a bad thing. I think they're solving a problem today, and people are paying for them because they see it as providing some value in some way. I guess I'm convinced, looking at other industries, that players who have ability to work with each other on behalf of their customers do have an API-type structure, and there's often, but not always, some form of intermediary or market maker. I think there'll be a small number of players like Surescripts that will act as an intermediary or market maker in the middle, because there's things that are helpful for a network to do to help individual parties. I don't want to do everything peer-to-peer. It's just too hard. I want to delegate security. I want to delegate authentication. I want to delegate various forms of credentialing to a third party like Surescripts. I'm really happy with that, if I can get that done to some sort of HISP. But Adrian, I do think the main thing is we got to see interactivity based on these new internet-style interfaces have to emerge. There's no question about it. And the problem is it's difficult to put it in regulation right now because the standards aren't quite ready for prime time. So I think what ONC did, which was to create a window that says you may adopt an API, and if you do, it will help you meet these standards, I think is actually a pretty smart technique. I personally think that'll pay off. I think personally that will mean that other things will diminish over time. But I don't think it'll be next year. I think it's going to take a couple of years to get there.
So, but just to wrap on your question, do we actually aggressively have to switch off direct HIEs, blue button, who knows what? I mean, my sense is that if the API stuff works, and by the way, we were just in the basement talking about it, and there's not a lot of people doing it.
We're
conspiring.
We
not
were.
a lot
It
of people.
awful.
It's great. It's really cool. It's really exciting. It should, when Anish is cheerleading as ever. Not a lot of people doing it, right? We find like one certified EHR company has done some of it, and they have like a few users. My chiropractor happens to be one of them, but it's a tiny company, right? Now we do have Epic and Cerner and the guys in the room, so we've got the right people in the room. But even saying that that's going to be enough, given that many of those companies at McKesson, but that have got, are involved in these other the dark networks or in the Commonwealths or whatever else. To me, it's tricky to say that you know, they're going to do one or the other. But if it's incredibly valuable and it fits the value chain, so if it actually works technologically and it actually makes sense in the value chain, in other words, it's advantageous for payers and providers to get together and use this stuff properly, my suspicion is that it'll win and everything else will die.
Yeah.
Because that's what's happened to the rest of the internet. But, you know, we have to see. That's our problem. Our problem is still not in this room. Our problem is in the wider world where, you know, the $117,000 assistant surgeon. You know, that's the problem where he can charge it and get away with it or get something, and he isn't forced to be in some kind of value network looking after the overall population health. That's our biggest problem, and hopefully CMS will help us fix it in the not too distant future.
Well, thank you very much. Now we're going to, sorry, I'm running late. You can certainly try and
there's
catch them
beer now.
afterwards. Yeah. So want to take a second to thank everybody on the panel. Thank all of you for attending. Certainly very interesting discussion, and I look forward to being back here next year and hearing what the grades are then. Thanks, guys.
Thanks, Tom. Great job.
Thanks, Tom.